Post-operative pain is of utmost importance for early mobilization and improving well-being of patients. This should be the primary concern of every anesthesiologist. Good morning. Today, I will be presenting to you a paper entitled Efficacy of Using Pregabalin versus Placebo as Preemptive Analgesia for Post-Operative Pain Management After Modified Radical Mastectomy, a randomized controlled trial. Modified radical mastectomy procedure involves removal of breast and lymph tissue and could result in nerve, muscle, and tissue damage. It was reported that pain is the most distressing symptom post-surgery. With a pain score of 4 to 8, this acute pain may predispose to development of chronic pain. Hence, its optimal management is recommended. Treatment of postoperative pain should be multimodal and opioid sparing to accelerate recovery and avoid potential side effects. One of the evolving clinical concept is preemptive analgesia, which involves the introduction of analgesic regimen before the onset of nauseous stimuli, with the goal of preventing sensitization of nervous system to subsequent stimuli that could amplify pain. It continues to be the controversial area with a large and growing clinical and experimental literature. The following are the commonly used preemptive analgesics. Pregabalin is a synthesis derivative of gabapentinoid and its structural analog of gamma-aminobutyric acid, is shown to be effective in several pain etiology, with the following pharmacologic property. Another is celecoxib. It is a COX-2 inhibitor that has the following role in perioperative pain, with the following pharmacologic property comparable to pregabalin. Hence, this study was formulated to determine the efficacy of preemptive pregabalin relief to post-operative pain of those who will undergo MRM procedure compared to celecoxib, which was used as an active placebo, with the following specific objectives. This study is considered significant, knowing that preventing acute pain among breast surgery may also prevent chronic pain called the post-mastectomy pain syndrome. The results may serve as basis to produce a protocol to preemptive pain management to uphold efficient anesthesia care, especially through pain management. It will also help educate doctors on alternative ways to minimize opioid use that will likewise benefit the patients. This is a randomized controlled trial with the following inclusion and exclusion criteria. After approval from IRB and acquiring informed consent, enrolled patients were randomly allocated to two groups. Treatment group, which received pregabalin 150 mg capsule, and control group, which received celecoxib 400 mg capsule. Both were given approximately 2 hours prior to the procedure. Allocation concealment was performed using serially numbered packets, which were prepared by a person independent of the study. Individuals not part of the study were asked to pick a packet, and the serial numbers were noted. Master list of the serial numbers was kept by the individual not involved in the study. Patients were given general anesthesia and given diclofenac 75 mg IV and paracetamol 900 mg IV as their post-operative pain medication. One patient under pregabalin had allergic reaction to diclofenac, and another patient from the same group underwent tram procedure. The pain assessment tool used in this study was explained and given to the patient and her relative for proper use at the ward. The verbal descriptor scale was modified and set to VAS 1 to 4 as mild and VAS 5 to 10 as moderate to severe. VAS scores were recorded at the following time interval. The patient was instructed to ask for the rescue dose at moderate to severe pain or as needed. Time to first opioid rescue dose was recorded. The following are the statistical methods used with a significant correlation set at p-value of 0.05. With that, this study revealed the following results. Baseline demographic characteristics of two groups were comparable. The pain scores of two groups were significantly different at 30 minutes to 10 hours postoperatively. Celecoxib group had significantly higher VAS scores than pregabalin group. However, The trend in pain score across two groups is not significantly different, wherein pain scores were higher in the first 10 to 14 hours post-operatively and decreasing thereafter. Patients given celecoxib had significantly higher incidence of moderate to severe pain, with p-value of less than 0.05. The two groups were compared by occurrence of by age and BMI and showed no significant difference in the occurrence of moderate to severe pain. The time to first opioid use in the patient given pregabalin was longer than patients given celecoxib, but that was not statistically significant at p-value of 0.28. Majority of patients did not experience any serious side effects. The result of this study is the same with the results from previous studies that used pregabalin as preemptive analgesia for different surgical procedures, such as laparoscopic cholecystectomy, middle ear surgery, laparoscopic sleeve gastrectomy, and simple mastectomy. Celecoxib, on the other hand, showed less efficacy on postoperative pain of post-MRM patients. This is in contrast to previous studies that proved its effectiveness as preemptive analgesic on different surgical procedures such as facelift surgery, oral surgery, and knee surgery. Knowing the mechanism of action of two groups being compared, they have properties that inhibit pain signals on the peripheral nervous system. However, despite the comparable pharmacologic property, the efficacy of pregabalin over celecoxib can be justified by the ability of pregabalin not only to reduce the somatic but also the neuropathic component of the pain perceived by the patient after MRM procedure. This is in line with the theory proposed by Charles Bell on origin of pain. To sum it all, this study proves that pregabalin is an effective preemptive analgesic for patients undergoing modified radical mastectomy. Further studies with larger sample size are recommended to create guidelines on specific surgeries, taking consideration the length of surgery and anesthesia to know the proper dosing of preemptive analgesic. Thank you.
Okay, aside from doctors and nurses who are blinded in this study,
The person assessing the pain score. Well, the anesthesiologist on duty on the post anesthetic care unit was also blinded of the study, and the relative the relative that is assessing the pain score of the patient at the ward.
what estimates were used in the sample size computation?
Sorry, ma'am.
What estimates were used in the sample size computation?
It is the previous journal that proves the efficacy of pregabalin over a certain procedure. I forgot. And also the census of patients undergoing MRM in our institution.
So how did you compute? How did you calculate your population with your research?
It was using the sta the data was encoded and using an application for the computation of the sample size. It was there was an application used by my statistician on computing the sample size based on the same number of population, almost the same number of population and sample size used by the reference journal used in this study.
Okay, when you make a head-to-head comparison between two drugs, you ought to state in your hypothesis whether you're trying to do a superiority trial or a non-inferiority trial. Would you know the difference?
Sorry.
kung anong ibig sabihin. For the information of everybody, pag sinabi mong superiority trial, one drug is better than another. Pag sinabi nating non-inferiority trial, one drug is as good as another. In most instances, pagka driven by pharmaceutical companies, they just look at non-inferiority trials kasi mas makikita lang nila as good as, but you cannot prove that one is really better.